Starting with this ocular pathology session. So first I would like to call upon Dr. Shreya Patel, presenting as pediatric massive B-cell non-Hodgkin's lymphoma, effective chemotherapy in a 13-year-old.
Good evening. My case is a rare case of pediatric orbital non-Hodgkin's lymphoma with significant response to chemotherapy. There was an 11-year-old girl who presented to us with protrusion of eyeball, downward displacement of eyeball. She also had a diminution of vision, watering and redness along with lid edema and cosmetic deformity since 2 months. On examination, there was 4 cm downward and outward proptosis with exposure keratopathy. The incisional biopsy was done and it came out to be lymphoplastic variety of non-Hodgkin's lymphoma, and the patient was referred to the oncologist. But because of negligence by parents, they were lost to follow-up, and they came back to us after a year. And 1 year later, the mass had significantly increased. There was facial disfigurement, loss of normal anatomy, involving the left eye, periorbital region, and extending up to the malar area, bridge of nose, and projecting outwards. The surface was hard, irregular, with areas of ulceration, necrosis, crusting, and the margins were ill-defined and blending with the surrounding tissue. MRI was done, which came out to be a heterogeneous and the mass was also extending up to the frontal region, but there was no systemic metastasis. Other investigations were done that included bone marrow biopsy and cytogenetics. It came out to be AML-M2 also. So she had a systemic correlation with AML-M2 because the T821 was positive, also CD13, 33 and MPO were positive. The management was started by the oncologist with lymphoplastic induction protocol, vincristine, daunorubicin, cyclophosphamide and prednisolone. Later on, when it came out to be AML-M2 subtype, the patient was shifted to AML-specific chemotherapy that included daunorubicin plus cytarabine, and for consolidation phase, high-dose cytarabine was given. GCSF was also given for neutrophil recovery. During the chemotherapy, the patient suffered massive subhyaloid hemorrhage in the fellow eye, which led to diminution of vision in that eye. But at present, the patient has visual acuity of 660, pinhole 624, but she was not able to recover the original vision. She also had systemic side effects due to herpes and mucocutaneous blisters and herpetic stomatitis. But patient after chemotherapy, the orbital mass reduced significantly within 4 months. Visual prognosis remained poor and patient is clinically stable at present. Literature says that pediatric orbital non-Hodgkin lymphoma accounts for less than 1% of the non-Hodgkin lymphoma, and reported incidence of pediatric orbital lymphoma is only 0.12 per million per year. Unlike Burkitt's lymphoma, lymphoplastic variety is also specifically very rare, and large orbital masses more than 8 cm are exceptionally rare. It is usually linked to delayed diagnosis or aggressive disease. In present case, we came to know that the orbital non-Hodgkin lymphoma is rare but chemosensitive tumor. Large size was due to delayed follow-up and socio-economic barriers. Systemic evaluation is critical because it was able to find out the occult hematological malignancy, that is AML. Early diagnosis could have prevented visual loss in this case. AML with T821 has relatively favorable prognosis. Also, I would like to end with a short review of literature. Across pediatric primary orbital non-Hodgkin lymphoma, no cases with concurrent AML have been identified. Adult cases do exist, but pediatric coexistence is exceptionally rare, and this underscores the uniqueness of this case. Thank you.
Any questions? Anyone? Thank you, Dr. Shreya. Next. She is presenting as unmasking a rare malignancy, eccrine mucinous carcinoma of the lateral canthus.
Good evening, I am Dr. Ritik Hani. I am presenting a case for primary cutaneous mucinous carcinoma. It is a rare, low-grade malignant tumor, preferentially arising from the head and neck region, particularly in the eyelid. It is slightly more common in men in the age group of 50 to 70 years. Clinically, it may present as slow-growing, solitary, asymptomatic, flesh-colored nodule, or can have ulcerated lesion. Due to its varied clinical appearance, the differential diagnosis ranges from benign to malignant conditions necessitating histopathological confirmation. In my case, a 68-year-old male patient presented to us with right eye lateral canthal swelling since 5 to 6 months. The swelling was non-tender and progressively increased in size. He also has a history of similar lesions 3-4 years ago, which was surgically removed, but no documents were available with him at that time. Patient is known case of hypertension and diabetes mellitus type 2. On examination, both eye visual acuity was 6/12 partial. Right eye showed non-tender cystic nodular swelling of 2:1:2.5 centimeter over the lower lid lateral canthus. Rest ocular adnexa, anterior segment and posterior segment were within normal limit. Left eye was also within normal limit. We managed this patient. We advised him right eye lower lid excision biopsy under the local anesthesia with histological examination. It showed squamous epithelium with dermis infiltrated by tumor arranged in lobules with pools of extracellular mucin and floating cellular nest arranged in cribriform, papillary and solid pattern comprising cells with low-grade nuclei and eosinophilic cytoplasm. No mitosis or necrosis was seen. So impression shows low-grade adenocarcinoma with extracellular mucin, which is favoring the eccrine mucinous carcinoma. Patient was advised further immunohistochemistry to confirm the diagnosis, wide local excision with or without reconstruction under the local anesthesia, and also the metastatic workup in form of chest X-ray, ultrasonography of head, neck and abdomen, liver function test and renal function test. Immunohistochemistry panel showed cytokeratin 7 positive, estrogen receptor positive. It was negative for cytokeratin 20 and focal positive for synaptophysin and chromogranin. And it was also negative for P63. So the diagnosis is eccrine mucinous carcinoma of neuroendocrine type. Right eye wide local excision with 4 mm margin clearance with lower lid reconstruction was done under the local anesthesia. Post-operatively, no lack of thalamus was seen with almost physiological lid function, and metastatic workup came out to be completely normal. So in discussion, primary eccrine mucinous carcinoma of the eyelid is extremely rare but misdiagnosed due to non-specific clinical presentations. It can mimic benign lesions like cyst and chalazion, and also the malignant tumors like sebaceous gland carcinoma or basal cell carcinoma. So it requires histopathological examination with immunohistochemistry to distinguish it from the metastatic lesions. Wide local excision with the margin clearance is the gold standard, and reconstruction techniques help to restore the lead functions. Tumor has low metastatic potential but high local recurrence, so mandating the long-term follow-up. So in conclusion, eccrine mucinous carcinoma should be considered in recurrent or atypical periocular swellings. Histopathology with IHC is essential for the accurate diagnosis and exclusion of metastasis, and wide local excision with lead reconstruction ensure the good functional and cosmetic outcomes. Vigilant long-term follow-up is key due to risk of local recurrence. So recurrent periocular swelling should not be considered as chalazion every time. We should think beyond that. These are my references.
Any questions? Thank you. Anyone else who is presenting in this session? Dr. Neha Katuria, Dr. Rajat Sharma, Dr. Shweti Dhania, Dr. Surekha, Dr. Arvind, and Dr. Richa Khandilwal? None. That's it then. Thank you.